If that red cell transfusion makes the underlying problem worse, then maybe you haven't done the right thing.
Welcome back to Pete Script. I'm Zach Hodges.
And I'm Alice Shanklin.
And we're excited to share part 2 of our episode on red cell transfusion and critical illness.
Yes, and we are here today back with Kailey Remien and Jennifer Muszynski. Kailey is a third-year Pediatric Critical Care Fellow at Nationwide Children's. As she finishes her fellowship, she is leading the Social Determinants of Health ancillary group within the International Bacon 2.0 study. And we're glad she also decided to feature her interest in red blood cell transfusion. Jennifer Muszynski is someone you've probably seen if you've PubMeded PRBC transfusions in critically ill children before. She's a pediatric intensivist at Nationwide Children's as well. In addition to her robust research program on the immune effects of red blood cell transfusions, she serves as Nationwide Children's Hospital's Associate Chief Clinical Research Officer for Research Informatics.
Yes, part 2 is an application of all the core concepts explored in part 1. What do you do with that child with septic shock with worsening vasoactive requirement who has anemia? What hemoglobin threshold would you target? How about that child with severe ARDS and worsening respiratory failure, or even that child who is post-traumatic brain injury and has ICP issues? We explore this and more in part 2.
Yes, let's get right to the content.
Up to this point, we've laid the framework for understanding the rationale behind a red cell transfusion. We've explored what the guidelines say to guide our management of anemia in critically ill kids. We've talked about how in most of our patients, transfusing them above 7 grams per deciliter is probably unnecessary, might be harmful. Let's explore some clinical scenarios, though, where we might need to, in fact, push their hemoglobin above 7. So we have several planned for you. With each of these scenarios, perhaps explore what might be some clinical factors that would make you want to transfuse higher than 7. What target hemoglobin might you go after, if even that's the right question to ask? So your first case, we'll say you have a 4-year-old with septic shock and a worsening vasoactive requirement. Perhaps they're on a couple of different pressors continuing to go up. And we'll assume their hemoglobin is 7.5 to 8.
So Kailey.
Oh, yeah. You ordering the blood?
Yeah. You're
Sure.
You're the fellow on call and your resident just called you with that question. Mm-hmm. What are you going to do?
Well, with this patient, my resident shouldn't be calling me with that question because if we're having a worsening vasoactive requirement, I'll be standing there.
Oh, great
at
answer.
The bedside.
Yeah, so obviously this is a really common situation that we see a lot in the PICU. I think it depends, why are they in shock? Are they in hemorrhagic shock? Then yes, they're getting blood. I think other than that, if we are going up on vasoactives, they've been fluid resuscitated, I then will think about, particularly if our hemoglobin is less than 10, I will think about giving them blood to get their hemoglobin up to 10. And, everything in the PICU comes back to the oxygen delivery and meeting their demand. So I think other things that I look at too is what is their mixed venous, what's their lactate. Most of the time, if they're hypotensive and they're requiring titration of their vasoactives, their lactate is rising, their mixed venous is down. And those are all signs that PRBC transfusion would be helpful to them physiologically. Most of the time, we don't have a CVP, but if they need more intravascular volume and they've already gotten 60 per kilo, I don't really want to dilute them more. And another reason why I like to use POCUS at the bedside as well is I'll take a look at their function and their intravascular filling and then look at their IVC. And that sometimes will drive some of my clinical decisions at the bedside as well.
I would say similarly for septic shock in someone who has worsening hemodynamics and elevating vasoactive support, there, you wonder, maybe transfusing allows me to not just improve the scenario now, but allow me to wean some of the other support that we're giving. And maybe that's going to be beneficial. So I would tend to target a hemoglobin of at least 9 in that scenario where I have elevating vasoactive support. Also guided, though, by my measures of end organ function as markers of perfusion. So your urine output, as an example, is a good one. Lactate, obviously, we know in smaller kids can be tricky because the lactate can be a lagging indicator. And of course, in those smaller kids, we often might have a femoral line and not an upper extremity line where it's hard to get a reliable SVO2. And so that's where I'm relying on the sum total of hemodynamic data that I have available to me. But I'm going to lean toward probably a little bit of a higher hemoglobin threshold in that scenario of rising vasoactive support needs.
Nice. I'll take it. You've given us confidence for the septic shock transfusion. What about, and this is definitely the season, you've got a 2-year-old intubated with a pneumonia, worsening ARDS. Let's say you're either like needing to bag the patient frequently or you're inching towards non-conventional ventilation. Their hemoglobin is 7.9. What are we doing?
I feel like I don't think about hemoglobin transfusions probably enough in ARDS. Not that I would necessarily give it, but that it doesn't cross my mind enough. So I love this case. I'm always weary of making the patient worse with ARDS and giving them blood.
Yeah, this is definitely a matter of debate out there because there's a thought that, we should give blood so that we can decrease our FiO2 and not have as high an oxygen saturation. But at the same time, that transfusion may actually make the lungs worse. So I typically, unless I see signs of inadequate oxygen delivery, so similar to the septic shock question, I'm also going to be looking at things like lactate, signs of organ function, your SvO2 if you have one, and use that to guide rather than the lung function or the oxygen saturation in general. And so much of the time, unless I have hemodynamic concerns, I'm going to use a threshold closer to 7 for those kids.
I think that's pragmatic and wise. A case that we haven't even considered similar to this yet is trauma and traumatic brain injury. A kid who suffers severe traumatic brain injury, we know that intracranial hypertension can worsen oxygen delivery. So there might be something about the compartment of the brain that would be different. Say you had this kid with severe TBI who's intubated in your ICU and with this hemoglobin of 7.5 to 8. How might you manage that kid differently?
I do think that kid in that acute scenario where you do have increased intracranial pressure, that by definition is going to limit your ability to augment oxygen delivery to that compartment, which is a fairly important compartment. I probably am going to shoot for a higher hemoglobin threshold there. And the exact threshold, again, will probably be somewhere in the 9 to 10 range for those kids. And that's where things like your lactate and your SvO2 are probably less helpful because what I actually care about is what's happening in the brain. And that's where we think about, could our multimodal neuromonitoring help there? So do you have a brain tissue oxygenation available to you? The cerebral NIRS and change in cerebral NIRS can be another indicator for maybe what's happening hemodynamically within the brain that can help guide those decisions too.
Oh, wow.
We've been using transcutaneous Dopplers a lot more too, that have been really helpful for our decision making with our TBI patients.
Oh, how are you using the TCD results for blood transfusion specifically?
We have several people in our unit that are very, that's their interest in the PICU. And so if there were signs that there's not good blood flow, we were giving it to augment any oxygen delivery that was getting to those areas. But the one time that really stood out was oh no, their TCD shows that they have great blood flow. It's okay to let them sit at they were at 8. Mm-hmm. But we were going back and forth on if we needed to augment that oxygen delivery.
Oh, nice.
Yeah, so looking for signs of cerebral vasospasm, which may not be otherwise detectable, that might also prompt the decision point of needing perhaps a higher hemoglobin. Although how that interacts with the cerebral vasculature is another unanswered question.
Mm-hmm. No, this gives me confidence.
Yeah.
I was going to say that my floor for TBI patients was 8, but hearing you guys shoot for a 9 or 10 definitely gives me confidence to do the same. Those outcomes are a whole other body of work, right?
Yes.
Kind of what I've identified, or at least reflecting on our conversation thus far, in these scenarios where it might be indicated to push the hemoglobin above 7, it seems like there's this ceiling around 9 or 10. And whether that's just intuitive based on your practice or evidence, it seems like if we push hemoglobin much past 10, it's probably with diminishing returns. Do you see it the same way, Jen?
I do see it the same way. And I would say some of that is convention, but some of it is, if you take the patient population that you might anticipate would tolerate anemia the least, being the cyanotic congenital heart disease, and the fact that at least in the RCT that's been done, there weren't differences detected between a hemoglobin of 9 and 11 that gives me some sense of confidence that 9 or 10 maybe is the sweet spot. I think 10 also comes from some of the early goal-directed therapies for sepsis trials and the resultant surviving sepsis guidelines. That's where that number 10 came from. And the one study in pediatrics that looked at application of early goal-directed therapy that showed an improvement in mortality. One of the main differences between standard of care and early goal-directed therapy in that trial was transfusing to a hemoglobin threshold of 10 in the setting of evidence of lower oxygen delivery to consumption ratios. So I think that's where it comes from. Is it a strong evidence base? No, but it's not nothing.
Nice. Well, we'll take it. That's very interesting. All right, Zach, this is a question for you too, because of UT Southwestern's ECMO reunion. We have patients on VA or VV ECMO with impaired oxygen delivery. How are we transfusing them?
I will say it will be hotly contested on rounds. Will be the first conversation. Maybe first with VV ECMO. So many of our kids with VV ECMO have dual lumen cannulas placed in the right IJ. And in our smaller babies, they will have significant recirculation. That being, the oxygenated blood that's coming from the ECMO circuit is being delivered into the right atrium, but subsequently being resucked right back out, taken back to the ECMO circuit to be oxygenated again. And of course, that blood is not going to participate in oxygen delivery. So in our smallest kids who have the worst oxygen delivery, and we would typically use parameters like NIRS and lactate, and markers of organ function more than we would the saturation, right? So those kids that have worse oxygen delivery and perhaps even more recirculation, we would target a higher hemoglobin concentration. There's going to be quite a bit of variability there. There would be some themes of not wanting to push it past 10, kind of what we've already said so far. Would you ever see it above 10? Perhaps. But I think the other side of that continuum is actually more interesting. The kids who perhaps have the bicaval single lumen cannula, who perhaps don't have as much recirculation, seeing kids with saturations in the 80s and seeing, the venous saturation on the ECMO side being in the 60s to 70s. I don't have published data about this, but we would commonly let those kids, have their hemoglobin drift, whether it's 9, whether it's 8. And you think about the transfusions these kids require, that's saving them so much blood product.
Yeah. And important, the clinical note of don't freak out just for a stat in the 80s in a VV patient.
And I will say, to put a fine point on VA ECMO, you're assuming that there's either profound vasoplegia or there's myocardial dysfunction. So you are essentially delivering the oxygen for that patient. So it will be common in our practice early on the resuscitation, after the cannulated VA ECMO, do target higher hemoglobin threshold. Maybe it's around 10 or so. And we would then follow all those normal parameters of, lactate and organ function. I think, though, if you're getting to the point in VA ECMO where you're like letting the hemoglobin drift to 8 or perhaps even 7, and organ function is good, do they still need to be on ECMO? You know what I mean? So,
yeah.
So I guess I don't see us letting the hemoglobin drift on VA ECMO near as much.
Yeah.
Nice. What about nationwide?
That's so interesting that you say that, because we often worry more about the kids on VV ECMO than VA ECMO, because the idea is, well, they're hemodynamically supported on ECMO. But this has definitely changed over time. So when I was a fellow and early faculty member, our ECMO order set, it was just reflexively the red cell transfusion threshold was a hematocrit of 35, which is actually hemoglobin of 12. And it wasn't even a discussion. It was an order set. The bedside specialist would just call down to the blood bank to give blood if the hematocrit went less than 35. And then over time, that drifted down to 10. And then now I would say similarly for the patients, once they've gone on. So once they've gone on and they're stable and the measures that we're following for hemodynamics, I'm speaking of the VA patients now, have stabilized, we may let that hemoglobin drift down to around 8. I don't know that we'd go much lower than 8, only in part because of this is a population, of course, that has at risk for hemolysis and bleeding, and for that hemoglobin of 8 now being 7 later. So we'd like to leave a little bit of a cushion. But then also thinking about when you're ready to start your trials, maybe augmenting that hemoglobin again in order to tolerate some hemodynamic instability to make sure the kid's going to come off ECMO okay. For VV, I think our approach is similar, that the kids are often going to go on a little bit higher, but if they're stable, we will likely let them drift a little bit, probably closer to that 8. I would say 8 to 10 is now a discussion point, as opposed to a just transfuse based on a number for our ECMO patients as well.
Oh, nice. All right. Case number 5, a nice light one. The neonate with cyanotic single ventricle heart disease. Let's talk about right when they're born, before their stage 1 palliation.
No comment.
I don't know.
Well, am I allowed to say we're a split unit and I haven't set foot in a CTICU for
that's fair.
15 years?
I think that's fair. I would refer us to Dr. Jill Chillette, who I think is the chief of the Rochester PICU CICU for that.
Yeah, she is amazing.
We'll talk with her separately.
That actually is a really good separate topic.
Mm-hmm.
When I was looking things up for this question, we talk a lot about hemoglobin goals, and then reminiscing on my CTICU time, it's always hematocrit. We are always talking about their hematocrit. We are never talking about anything else. And it was just so interesting to read some of the literature and then be like, and that's not what we do at the bedside.
Yeah. No, we did hemoglobin of 12, I think. But yeah.
Yeah. It's one of the things that we talked about in the taxi group was this disconnect between the ECMO and VAD and cardiopulmonary bypass world, often talking in terms of hematocrit, and everybody else is talking about hemoglobin.
Mm-hmm.
And there's that general rule of thumb. If you divide by 3, that's the conversion, but it's not exact. And so you really aren't actually talking about apples to apples comparison.
And I feel like the congenital heart patients are the place where it's most notably not apples to apples, because their bone marrow's kicking in and giving them some polycythemia and all of that. And so it's not always applicable.
Interesting.
Yeah.
So as we wrap things up, Dr. Muszynski, we brought you here for this topic. We know that this is your area. I'm curious, as we think about research questions moving forward, how did you get yourself in this area of research? And then do you have any tips for sort of building that topic, building your early body of work, and sort of establishing yourself as an independent investigator?
Yeah, absolutely. That's a great question. I started out in research thinking about infection and immune function. And I was very interested in immune function, specifically critical illness associated immune suppression. And my mentor at the time brought by the lab, I still remember this day, there was a paper published in New England Journal of Medicine in 2008 when I was still a fellow that looked at an association between the storage duration of blood given to adults who had undergone cardiopulmonary bypass and nosocomial infection. And he just asked the question of, do you think red blood cell transfusion could be immune suppressive? And could we test that? And I said, I don't know, maybe. And so as part of my fellow research, created an in vitro transfusion model where I took monocytes and I exposed them to different red blood cell products. And that started the transfusion portion of my career. And I had some observational studies where we were looking at immune function before and after transfusion. And as I continued that body of work, really opened the doors to all of the various questions that we have that all boil down to the one big question that I have, which is I'm standing at the bedside in front of a patient, and I just want to know, if I give you this bag of blood that's in my hand now, am I going to make you better or am I going to make you worse? And it's that big question that really has driven the rest of my program of research. So I think number one is finding that big question that really drives you. The other piece is mentorship and collaboration along the way. I owe so much of my career to the Pediatric Acute Lung Injury and Sepsis Investigators or Policing Network and the BloodNet subgroup, and the mentorship and collaboration that I found there that now I really try to give back, because that was so fundamental to my career and my career development. And so if I were going to give any 2 pearls of wisdom to trainees or junior faculty, it's find that question that drives you and find your village. Find your mentors, find your collaborators, find those folks who will do the work with you.
No, that's incredible. There are common themes of guests that we have the opportunity to chat with. And, finding that question that really motivates you, that's a common reflection. And then reflection of like finding great mentors. And then as you build up, your skills, look for a way to give back and keep carrying that forward. Jen Muszynski and Kailey Remien, this has been incredible. We've had such much fun unpacking, all of these baseline pathophysiology knowledge, and then talking about clinical applications of red blood cell transfusion and critical illness. To give you guys the floor and for the final words, perhaps Kailey first. Any points that you'd like to highlight for the listeners? Anything else you'd like to mention before we wrap things up?
I think my parting thought would be for red blood cell transfusion, but also everything that we do, continue to think about how we can explore and learn more, because what we know today is likely not going to be true tomorrow if we continue to ask those questions and really pursue how do we do this even better in the future.
Oh, well, thank you so much for joining us.
Thank you very much.
And thank you for listening to this episode of Peds Crit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of Peds Crit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of Peds Crit laptop stickers, and if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening.